So I'm a first generation Indian American, my parents came from India, and as a result, I have always seen myself as a bridge between two very different worlds. I've lived this experience of inside the house, decades and centuries of culture and tradition, and on the outside, a testament to my parents' determination to build a better life for themselves and their families. In addition, I've always loved learning, be that from any source, whether that be from an anatomy textbook that teaches you about human biology, whether that be through random conversations with strangers, or whether that be through the YouTube videos I watched to pick up woodworking as a hobby over the pandemic. So what does being this bridge between two worlds really mean, right? Constantly being exposed to this has led me to really value interdisciplinary collaboration, international collaboration, and just any sort of collaboration that brings together multiple disciplines and multiple perspectives. Because I think that the best work in any field can be done at that intersection. So now kind of going into me and my interest in career-wise. So from a very early age, my interest in the sciences and my interest in working with people pushed me to pursue a career in the medical field. So in high school, I went ahead and did all the typical pre-med things. I did all these different AP classes. I went to soup kitchens, I volunteered. I was so excited to go ahead into this field. But then in my junior year of high school, I had a very unique experience. I worked with people that were from the diaspora of my parents' home state of Odisha, India, which is a smaller state on the eastern coast. And what I did with that was I worked to funnel resources and mentoring to innovative social enterprises that were working on the ground in Odisha, India. Through this, it was almost like an incubator program, but on a smaller scale. And through this, I got to work with a variety of people. I worked with local community members, I worked with engineers, entrepreneurs, policymakers, I worked with the Indian Ministry of Commerce and Industry, and through this experience, I, again, reinforced that idea that interdisciplinary collaboration was important. But another thing kind of came into the picture. This idea that if we are able to work directly with community members and fund different initiatives that are started by community members themselves, it is the most effective way for us to create change. If we are able to work with these community members, they understand the needs of their communities the best. And as a result, they're able to solve it the most effectively. So that's what I did. Through this experience, I really learned more about how the importance of community-led, need-based solutions. And while I really got this passion for working with social issues and economic issues, at the time, I didn't have the insight to really see how that fit into my pre-medical coursework, my interest to become a doctor. So now, fast forward to getting into college, again, declaring P&B as my first major. I was interested in those economic issues, so I had my econ degree. But at the same time, I started working in hospitals. So I worked with patients, worked with the mobility medicine program at Harvard Hospital, during which I worked with patients to help them recuperate and help them just maintain their health by walking around with them and assisting them on hospital floors. So while I got invaluable insight really into the role of medical professionals, whether it be nurses and doctors, anyone else on the floor, I learned more about how the healthcare system itself works. I think the most insight that I had gotten was through my conversations with patients. One notable incident that I remember was a woman that came in. She only spoke Spanish. She really was not fluent in English at all, but the majority of our medical team only was able to speak to her through a translator. I'm somewhat proficient in Spanish, and so through a combination of talking with my hands and just my minimal Spanish knowledge, I was able to make a connection with her, and she was very excited to see that she was being understood. In this base level of cultural competency, we had a discussion, and we were talking about her life and how she had struggled to really put food on the table for herself and her 3 kids throughout her life after her husband passed away unexpectedly when she was in her 30s. She talked about her struggles with food insecurity because she lived in an area with lack of access to supermarkets. She talked about struggling to pay utility bills. She talked about childcare concerns and how sometimes she would have to go to work and there was no one to watch the kids. And all of these stressors all combined really pushed her to think that maybe the reason that I had a heart attack at the age of 48, I believe, a pretty early age for a heart attack at that point, maybe that was because of these stressors. So that really got me thinking. Another incident that happened in the hospital was me talking to some of the physicians that were working on the floor. I remember one conversation with one of these physicians when they mentioned that they had to discharge a patient into their car because they didn't have a house to live in. They didn't have a bed to heal in. And as a result, a few weeks later, they were readmitted to the hospital because their surgery, the stitches all were unraveled. The results of the surgery were not effective solely because they had no bed to heal in. So it really got me thinking, why is this happening? We are in a space that we have a very large healthcare system, be it one of the most inefficient ones out of all developed countries. America's healthcare system actually has the highest per capita health expenditure with some of the least better health outcomes. So I started thinking about my social and economic background in high school, and I was like, can I bring any of this into these studies? And coming to college, I found the field of global health. Global health is a field that explicitly pulls in social and economic and cultural factors into our understanding of health and how we treat people. And as a result, we're able to build better health systems and have better health outcomes. So now I will jump into the field of global health itself. But first, I'd like to start off with a number. 3.8 billion. 3.8 billion, half of the world's population, lacks access to essential health services. So clearly the need for global health and better health practices are evident. But when I say the word global health, right, what kind of thoughts come into your head? What images come into your head? Often when I'm doing talks like this and presenting, and I say global health or even conversations, the image that comes to people's minds are those of medical professionals, primarily in the global north, so America, Europe, more high-resource areas, going into low-resource areas, whether that be in India, countries in Africa, Latin America, things like that, to go and provide care. Now, don't get me wrong, this sort of care is important. We do need to foster global north-south collaboration and ensure that everyone has access to healthcare. But this sort of work is a very small part of what the field of global health really is. If you look at global health, it is actually defined by the Consortium of Universities for Global Health as an area for study, research, and practice that places a priority on prioritizing health and achieving equity in health for all people worldwide. In essence, it is the health of us all. So that is not just people in low-resource areas, it's also people in our own communities, people who are in our local towns, in our state, in our country. So what does this really mean, right? So going into global health, what are these misconceptions really doing? Before we get into the field of global health itself, it's important to talk about the history of global health as a field. It has been in the past, and rightly so, been accused of holding up colonial healthcare systems. Decolonization of global health is a very upcoming topic, and it's really looking at how the history of colonization has resulted in the inequitable distribution of resources between high-income and high-resource areas, or the countries that did the colonizing, and lower-resource areas, or the countries that were impacted by colonization. This impacts the development of health systems. This impacts everything from how much funding a country is getting, to which diseases have a priority in the global health agenda, to who is even at the table. So you may think that this was, okay, colonization happened years ago, there's no impact on this now. But in reality, when I talk about which diseases get funding and how these health systems have been inequitable to this day, there's a very clear, explicit example which I want to talk about right now. In 2018, 2019, there was an Ebola outbreak, which I'm sure a lot of you probably remember, and it got a lot of international attention. We had medical professionals from all around the globe go into areas that were hardest hit in Africa, specifically in the Democratic Republic of the Congo, and go in and really fulfill these roles where they're setting up clinics and treating patients. One thing that's interesting is this is a press release from Doctors Without Borders, one of the organizations that was sending in doctors. And what was happening is the Ebola response was failing. Why? Because there were security concerns, because the village and the community people themselves were actually attacking the healthcare workers and the health clinics. So this sounds kind of counterintuitive, right? Why would you go ahead and hurt the very people that are coming in to help you? And it's because in this whole discussion, Community members were never asked, nor were they informed as to what was going on. We had healthcare professionals coming from all across the globe into this space where they didn't understand the cultural beliefs and end-of-life rituals that these communities really believed in and were important to their way of life. There were no community leaders that were being consulted. And as a result, they had to actually shift away a lot of these healthcare programs. In addition, community members were confused. Why is Ebola specifically, as a disease, being addressed with so much international funding and attention when diseases like malaria or a lot of other diseases that affect African and Latin American countries specifically pushed off to the side with limited global health funding due to them being deemed neglected tropical diseases? What is this term, neglected tropical disease? There's still people that need healthcare that are suffering from diseases, yet we only cared about Ebola. Why is this the case? Could it be that Ebola had the risk to spread to Western countries? It had the risk to affect people in the global north, the people that were at the table for global health funding, rather than the people that were actually suffering from other diseases that had a much greater death burden and illness burden. So clearly, there's a lot of work to be done in this space for decolonizing global health, and it's an ongoing conversation. And there have been multiple papers. This is something from the New England Journal of Medicine talking about this whole Ebola outbreak. So now I want to go in to address two main misconceptions in the field of global health. The first, global health is the health of the other. What does this mean? So we tend to think that, again, with those two images, right? Going into the global south, we need to travel, we need to go to these other places where people are suffering and give them our resources and make sure that we have all this healthcare systems set up. But is this really the case? Are healthcare systems really just problematic in other countries? I want to start with this statistic. We're in Connecticut right now, so this is in the West Hartford Center, relatively white, affluent area in Connecticut. The life expectancy there is 84.6 years. Now I'll take you 10 to 15 minutes of a drive into Northeast Hartford, a community that has a very high population of BIPOC communities, and it's not as affluent as West Hartford, and the life expectancy there is 68.9 years. So a 16-year life expectancy difference in the span of a 10 to 15-year drive. So are these low resource areas really just in international communities? And when we go into these international communities, right, you're not really aware of all of the cultural norms, all the cultural practices, and you're going to run into the same issues with not understanding how to give proper culturally competent care, as opposed to communities of our own, where we're able to go and help people that are suffering due to a lack of resources and create effective change. So before we move on to the next misconception, am I saying that no international help is necessary? I don't think this is the case. When we talk about colonization, right, it does lead to the ineffective distribution of resources. You do have situations where health and health prioritization has happened for the global north, and it hasn't happened for the global south. So I encourage global north and global south collaborations in terms of funding, in terms of a exchange of knowledge, of resources. Talk to local community members that are leading health initiatives on the ground in communities that are not our own, and fund those initiatives, work with them so that we're able to really connect the dots between the global north and the global south. So this misconception is a bit of a simpler one. Global health is a field that only has room for people in health professionals. I think this is a very dangerous perception that we have. I think we often think that global health is a field just for health professionals like doctors, nurses, and all that. In reality, this is the global health community. We're actually a very small snapshot of it. We need engineers that enable healthcare delivery and create innovations for us to be able to improve our global health outcomes. We need healthcare professionals. Obviously, this is a community that I wish to join in the future as a doctor in order to provide the actual medical care for the patients. We need public policymakers who are able to create the political ecosystem in which we are able to create our global health change. And lastly, this is a community that we don't think of often, but it might be actually the most important group, artists, because they have a critical role in operations like marketing and cultural connection that ensures that anything that we put into place actually does have an impact. So before I kind of wrap up, I do want to say that not everything is perfect, and we don't really, I don't think it's fair for us to think that we can go in and do everything perfect, find the first American, right? Even I, my freshman year, went on a service trip to Cusco, Peru, before I realized that some of these trips were very problematic. Because as I went there and I talked to some of the local community members, I had thought that this program was sustainable. But as I kind of worked with the people there, they said that the program really came into the space once every 6 months and would provide medicines that only lasted for like a few weeks or a month. So are we really creating sustainable community change? In addition, these healthcare camps that are being set up was actually interfering with government funding of healthcare infrastructure. So really, at the end of the day, when we look at building a future with health justice for all, there are a few things that we need to do. We need to ensure that we are building proper partnerships with and including everyone in this space, whether it be people from different disciplines, people from different parts of the country, people from different parts of the globe, and ensuring that the knowledge that we are sharing is equitable, and making sure that we're working with people on the ground and fostering community-led, need-based solutions. And with this, I think we'll be able to really connect the dots between ourselves, people across the globe, and people from all backgrounds, and create those interdisciplinary, inter-community ties that will ensure that we have a future that has health justice for all of us. Thank you.